Hello, today's discussion is about respiratory distress, etiology and definition of respiratory distress in children. The term respiratory distress is used to indicate signs and symptoms of abnormal respiratory pattern. A child with nasal flaring, tachypnea, chest wall retraction, stridor, grunting, dizziness and wheezing has respiratory distress. A careful physical examination must be performed when managing a child in respiratory distress. Nasal flaring, although non-specific, is an extremely important sign of distress in infants, but it may indicate discomfort, pain, fatigue, or breathing difficulty. This is a non-specific sign of distress. The state of responsiveness is another crucial sign. Lethargy, disinterest in surrounding, poor cry are suggestive of exhaustion, hypercarbia, and impending respiratory failure. Abnormalities of the rate and the depth of breathing can occur with both pulmonary and non-pulmonary cause of distress. For example, in disease of decreased lung compliance, such as pneumonia and pulmonary edema, breathing is rapid and shallow. This is due to decreased tidal volume. Whereas in obstructive airway disease, such as asthma and croup, breathing is deep with decreased tidal volume, but it's less rapid. Rapid and deep breathing without other respiratory signs should alert the physician to possible non-pulmonary or non-thoracic cause of distress, such as response to metabolic acidosis or stimulation of the respiratory center by encephalitis, ingestion of CNS stimulants, for example. Chest wall, suprasternal and subcostal retractions are manifestations of increased inspiratory effort or weak chest wall or both. Inspiratory stridor indicates airway obstruction above the thoracic inlet, whereas expiratory wheezing results from airway obstruction below the thoracic inlet. Grunting is most commonly heard in disease with decreased functional residual capacities, such as pneumonia, pulmonary edema, and peripheral airway obstruction, such as bronchiolitis. Grunting is when they exhale air against partially closed glottis. We classify cause of respiratory distress as lung pathology and non-lung pathology. Let's start from respiratory disease manifesting as respiratory distress. Clinical examination is important in localizing the site of pathology. Extrathoracic airway obstruction occurs anywhere above the thoracic inlet. Inspiratory stridor, suprasternal, chest wall, subcostal retraction, and the prolongation of inspirations are hallmarks of extrathoracic airway obstruction. Features of intrathoracic airway obstructions are prolongation of expiration and expiratory wheezing. Typical manifestations of alveolar interstitial pathology are rapid, shallow respiration, chest wall retraction, and grunting. The other is cardiovascular disease manifesting as respiratory distress. A child with cardiovascular pathology may present with respiratory distress caused by either decreased lung compliance or cardiogenic shock. This is that results in increased pulmonary arterial blood flow. Example, from left to right shunt, or increased pulmonary venous pressure due to, for example, left ventricular dysfunction from hypertension or myocarditis. They cause an increase in pulmonary capillary pressure and the transudation of fluid into the pulmonary interstitium and alveolus. This causes distress. The increased pulmonary blood and the water content led to decreased lung compliance and result in rapid shallow breathing, alveolar fluid, but as small airway obstruction as well. Wheezing as a sign of congestive cardiac disease is common in infants and young children and should be recognized. The third one is neurologic disease manifesting as respiratory distress. CNS dysfunction can lead to alteration in respiratory pattern and manifest as respiratory distress. Increased intracranial pressure may manifest as respiratory distress because it's a part of Cushing triad. Cerebral hemispheres and the midbrain lesions result in hyperapnea as well as tachypnea. Pathology affecting pons and the medulla manifest as irregular breathing patterns such as apneustic breathing, Cannestrock's breathing, irregular and ineffective breathing, or apnea. Severe CNS dysfunction can result in neurogenic pulmonary edema and respiratory distress due to excessive sympathetic discharge, which causes increased pulmonary venous hydrostatic pressure and increased pulmonary capillary permeability. Central neurogenic hyperventilation is characteristically observed in CNS involvement by illness such as urea cycle defect and encephalitis. Bradycardia and apnea may be caused by CNS depressant medications, poisoning, prolonged hypoxia, trauma, or infection. The other is toxic metabolic states manifesting as respiratory distress. Direct stimulation of respiratory centers resulting in respiratory alkalosis is encountered in intoxication involving agents such as salicylates and theophylline. Similarly, intoxication with general CNS stimulants such as cocaine and amphetamines may result in increased respiration. Carbon monoxide and cyanide poisoning or methemoglobinemia may produce respiratory distress. The fifth one is other non-pulmonary entities manifesting as respiratory distress. Sepsis and septic shock may cause acute respiratory distress syndrome with hypovolemic stimulation of baroreceptors, cytokine stimulation of respiratory centers, and lactic acidosis. Other indirect causes of lung injury include systemic inflammatory conditions, trauma, transfusion-related acute lung injury, and pancreatitis. Similarly, Lennard disease may manifest as respiratory distress by causing metabolic acidosis or by causing hypertensive left ventricular failure. This is all about respiratory distress in children. Thanks for watching.